Hi guys, today we'll be talking about the ulnar paradox. Paradox is something that is seemingly contradictory or which doesn't make sense if you think about it logically, which could still be true. So, coming to what the ulnar paradox is, I think the ulnar paradox is better explained if I explain to you with a normal example first. Imagine a nerve running from the axilla to the wrist region. An injury to the nerve at the level of the axilla usually produces more deformity and more loss of function than the injury to the nerve at the level of the elbow. Because on the way from the axilla till the elbow, it already would have supplied certain structures. And even if it gets injured at the elbow, whatever structures which are supplied at the arm level are usually spared. So I'll explain with the radial nerve, for example. So as you know, when the radial nerve exits the spiral groove, it pierces the intermuscular septum and travels from posterior to anterior and gives a nerve supply to the extensor carpi radialis longus, and slightly below it gives a nerve supply to the extensor carpi radialis brevis. So it divides into the superficial branch of the radial nerve and the deep branch of the radial nerve. Superficial branch of radial nerve is a sensory branch, and the deep branch of radial nerve supplies all the extensor compartment muscles. So imagine there's an injury here and the nerve supplied to the extensor carpi radialis longus and the brevis is spared, but the nerve supplied to the EDC, extensor digitorum communis, is gone. So as we know, the extensor carpi radialis longus and brevis are the primary extensors of the wrist, and the EDC is the primary extensor of the fingers. So if there's a nerve injury at this level here, the ECRB and ECRL are spared, but the EDC is affected, so this leads to finger drop. This is the lower nerve injury. Imagine a higher nerve injury at the level here where it just exits the spinal groove, a Holstein-Lewis fracture, where lower one-third of the humerus shaft is fractured with the radial nerve injury. The ECRL, ECRB and the EDC are affected. So this leads to wrist and finger drop. Higher nerve injury, more deformity. Lower nerve injury, less deformity, basically. Okay. When it comes to the ulnar nerve, this is an example of a clinical image with the ulnar nerve injury above the level of the elbow. And this is an example with ulnar nerve injury at the level of the wrist. As you can see, the deformity is less with higher nerve injury and more with lower nerve injury. So this is basically the ulnar paradox. Now why this happens, I'll explain. In order to understand this, we need to understand a brief anatomy and only the important muscles supplied by the ulnar nerve which are important for this lecture. I'll just limit that. Otherwise, we can go through the entire ulnar nerve course and the branches, and it's a lot. So, as soon as it exits from the cubital tunnel at the level of the elbow, which is formed by the Osborn fascia or the Osborn fascia, what happens is, I'm sorry, jumping. Okay. It runs between the two heads of the flexor carpi ulnaris, which it supplies, and also supplies the medial half of the flexor digitorum profundus. By medial half, what I mean is the tendons to the pinky finger and the ring finger, or the fourth and fifth digit. And runs distally, gives off two cutaneous branches, palmar cutaneous branch and the dorsal cutaneous branch. We'll talk about why that's important later. And after it crosses the wrist, it divides into superficial and deep branches. The deep branches supply the third and fourth lumbricals, which are important for us. So for this lecture, the FDP, which is supplied above the level of the wrist at the level of the proximal one-third forearm, and the third and fourth lumbricals, which is supplied beyond the wrist, is important. So to understand this completely, we need to understand what the function of the lumbrical is. So the lumbricals originate from the flexor digitorum profundus tendon and insert into the dorsal digital expansion or the extensor hood of the fingers. So the main function of the lumbricals is flexion at the MCP and extension at the PIP and the DIP. So basically this. This is the function of the lumbricals. Okay. So what happens if the lumbricals are affected? So imagine the third and fourth. So okay, wait, let's go back to the previous slide. So imagine there's a lesion at the level of the wrist. The flexor digitorum profundus is still spared, so it's active, whereas the third and fourth lumbricals are affected. So opposite to the function of the lumbricals, that's what will happen. So what will happen is there will be hyperextension at the MCP, and there will be hyperextension at the MCP, and there will be slight clawing of the fingers. Slight clawing, not much, because there'll be a lot of clawing of the fingers because the FTP is still active. So what will happen is there'll be a lot of clawing and there'll be hyperextension at the MCP. Now, imagine, I'll show you with another image. It will be like this, more clawing, and of injury at the wrist. Whereas, if the injury is at the level of the elbow, the nerve supply to the FDP is also gone, FCU is gone, and the third and fourth lumbrical is gone. So, it will be opposite to the function of the lumbricals, where there will be hyperextension at the MCP and there will be slight flexion at the PIP and DIP. Why there will be slight flexion is because the function of the lumbricals is to extend and help the extensor digitorum extend the PIP and DIP as it attaches to the extensor hood. So there will be slight flexion because of the loss of the lumbricals, and there won't be too much flexion because the FTP is also not active. So this causes less clawing. So that's basically the ulnar paradox explained. So in case of ulnar nerve injury at the level of the wrist, nerve supply only to the, okay, I'll just explain with the help of this diagram here. Nerve supply only to these ulnar aspect of the medial 1.5 fingers will be spared. This, the palmar region, the dorsal hand region, and the medial 2.5 dorsal fingers will sensation will all be lost. Why? So before the ulnar nerve enters the wrist, it gives off the dorsal cutaneous branch and the palmar cutaneous branch. So if the lesion at the level of the elbow, the nerve supply to the entire ulnar nerve distribution is gone. Whereas if it's at the wrist, the palmar cutaneous branch and the dorsal cutaneous branch are spared. Dorsal cutaneous branch supplies this entire green shaded region here, and also the palmar cutaneous branch supplies the entire blue shaded region except the fingers. So at a lesion which is below the level of the wrist, only the fingers, the volar aspect of the fingers, 1.5 fingers, will be sensation will be maintained, whereas the palmar region and the dorsal regions will be totally lost. So that's also how you can tell a higher ulnar nerve region from a lower ulnar nerve lesion. Thank you.